Hello dear viewers, this is part 3 of continuous renal replacement therapy in critically ill patients. In this video, I will be discussing what basic concepts a clinician should know about this therapy. To know nuances of therapy helps in making informed choices and navigating troubleshoots. I am Dr. Sunil Garg from Essentials of Acute Care. Which biocompatible membrane should I choose for the average intensive care unit patient? Biocompatible polysulfone, polyethersulfone, or polyacrylonitrile like AN69 membranes are used most commonly. Out of these, polysulfone is suitable in a vast majority of patients. This membrane is robust, cheap and resistant to contamination. In contrast with high adsorbent polyacrylonitrile membrane, polysulfone membrane do not adsorb antibiotics, which facilitates antibiotic adaptation during CRRT. What is the normal porosity of dialysis membrane? A classic membrane has a cutoff of 30 to 35 kilodalton. Membranes used for convection have similar porosity, whereas the cutoff value is lower, approximately 5 kDa or 5 kilodalton in diffusion mode. So effectively, classic CRRT membrane can be used for both diffusion and convection. What are high flux dialysis membranes? High flux membranes have a larger pore size and thus increase the clearance by allowing large molecules to pass through membrane as well as more ultrafiltrate flow for the same transmembrane pressure. Almost all novel biocompatible CRRT membranes are of high flux type. What is AN69 membrane? The AN69 membrane is polyacrylonitrile membrane which has a unique mechanism of action, so it can adsorb higher molecular weight toxins present in blood in addition to small and middle sized molecules clearance through diffusion and convection. How to decide type of CRRT therapy? It depends on your goals of therapy and underlying disease condition in addition to expertise and resources available. CVVHD and CVVHDF effectively clears small molecules like electrolytes, sodium, potassium, calcium, urea and creatinine through diffusion. CVVH and CVVHDF are effective for removing middle-sized molecules like cytokines and interleukin 6. Larger molecules such as myoglobin or some pro-inflammatory cytokines can also be removed particularly through hemofiltration and hemodiafiltration, with the specific removal being dependent on the membrane pore size and flow rates. While removal of myoglobin is not a highly efficient removal process, studies have shown that myoglobin can be cleared, particularly with high flux filters and high ultrafiltration volume. What are the factors affecting solute clearance? It includes CRRT modality. CVVH and CVVHDF are better at removing larger molecules compared to CVVHD. Membrane characteristics. The pore size of the filter membrane directly affects the size of molecule that can pass through it. Solute binding. The degree to which a molecule is bound to plasma proteins like albumin influences its removal. Free unbound molecules are more readily cleared. Blood flow and dialysate rates. These factors affect the concentration gradient and the overall clearance rate. Diffusion versus convection. Diffusion primarily clears small molecules while convection driven by pressure removes larger molecules. What membrane surface area should be used. When using unfractionated heparin and higher blood flow, surfaces of 1.5 to 2 meter square are needed. Membrane surface can be decreased when regional citrate anticoagulation is used. A 1 meter square surface is ideal, reducing blood membrane interactions and shear stress. Should I pre-coat or soak the filter membrane before use? The filter life of most membranes, even while using regional citrate anticoagulation, is improved after soaking them with 5000 international units per liter of unfractionated heparin. The contraindication for unfractionated heparin use should always be considered. How frequently should I change the filter? While using unfractionated heparin, it is recommended to change the filter every 24 to 48 hours, guided by filter pressure drop and transmembrane pressure increase. Regional citrate anticoagulation enables to maintain filter porosity up to 72 to 96 hours. If the filter clots or becomes clogged, it should be changed immediately irrespective of duration between change. Filter efficiency can be evaluated by calculating the ultrafiltration urea divided by serum urea ratio. If this ratio drops below 0.80, the filter should be changed. In some cases, filters are changed at 72 hours or when 780 liters of blood have been processed, whichever comes first. How to identify filter clotting? It can be done by closely monitoring filter pressure, transmembrane pressure and filter pressure drop. Filter pressure drop can be calculated by subtracting return pressure from filter pressure. How to prevent filter clotting? To prevent filter clotting in continuous renal replacement therapy, several strategies are employed, primarily focusing on anticoagulation and optimizing the extracorporeal circuit. Anticoagulation, particularly with renal citrate anticoagulation and heparin, and non-pharmacological measures like pre-dilution can help prolong filter life and reduce clotting. Introducing replacement fluid before the filter dilutes the blood, reducing the concentration of clotting factors and potentially decreasing the filtration fraction, which can be a factor in clotting. Maintaining optimal blood flow and regular saline flushage can help clear any clots that may have formed, particularly in the absence of anticoagulation. Minimizing blood-air contact in the circuit can also reduce clotting risk. What is sieving coefficient? The sieving coefficient is the ratio of ultrafiltrate to plasma solute concentration. Sieving coefficient 1 reflects complete permeability for that solute, means whatever concentration of solute is present in plasma is same in ultrafiltrate. Sieving coefficient 0 reflects complete impermeability. The major factors determining the sieving coefficient are solute molecular size, protein binding, volume of distribution, and filter porosity. What should be acceptable TMP or transmembrane pressure? In adults using continuous replacement therapy, the filter should be changed when the transmembrane pressure exceeds 300 mm of mercury. A transmembrane pressure between 50 and 250 mm of mercury is generally acceptable. Which drugs are removed by CRRT? Unprotein bound means free drugs which are not bound to albumin, and low molecular weight drugs are removed like salicylate, methanol, ethylene glycol, barbiturates, lithium, penicillin, carbapenem, aminoglycosides, cephalosporin, vancomycin, metformin. It is important to note that many antibiotics are also removed during this process, albeit to different extent. Which drugs are not removed by CRRT? Protein-bound agents, high molecular weight drugs, and drugs with a high volume of distributions are not removed. For example, digoxin, tricyclic antidepressants, phenytoin, benzodiazepines, beta blockers, except atenolol. What is the blood volume of CRRT set used in Prismaflex machine? For M100 set, it is approximately 150 ml, and for the M150 set, it is approximately 190 ml. What is minimum blood flow rate in CRRT? It is approximately 100 ml per minute. What is membrane surface area for different filter in Prismaflex? For M100 filter, it is 0.9 meter square, and for M150, it is 1.5 meter square. What are different replacement dialysate fluids available for CRRT? There are mainly four types of fluids. Prismosol 2 contains 2 millimole per liter of potassium. Prismasol 4 contains 4 millimole per liter of potassium. They both contain bicarbonate as an alkalinizing buffer. Hemosol B0 is a phosphate and potassium free, means zero potassium, and foxolium is a phosphate containing solution. It also contains 4 millimole per liter of potassium. What is an approach to determine optimal drug dosing during therapy? It is important to give an adequate loading dose, particularly with water-soluble drugs that have small volume of distribution, means less than 0.7 liter per kg. Calculate the loading dose based on the ideal body weight plus added weight from volume overload. Regarding estimation of maintenance dose, for many medications like pain medications, sedatives, vasopressors, titrate the dose based on the clinical response, goals or endpoints. For medication for which there is not an observable clinical response to follow, titrate the dose based on plasma concentration. For medication that cannot be titrated to clinical response nor easily measured, estimate the dose based on CRRT clearance and residual kidney function. Here I finish. Thanks for watching this video. Please do not forget to subscribe to this channel. See you in my next video on CRRT part 4. Till then, bye and take care.